A very good evening and welcome to one and all present here for international webinar series on DENTOPHARM on topic Physiology and Pathophysiology of Bone Remodeling. I'm Dr. Ramya, part of Dental Education Unit and Senior Lecturer at Sri Balaji Dental College and Hospital. Will be highlighting you about this program today. I would like to welcome our chairperson, Dr. Sri Nisha ma'am, Registrar Dr. Bhuminathan sir, Principal Dr. Jimson sir, and Dr. Sumati Jones ma'am, Head of the Department of Pharmacology at Sri Balaji Dental College and Hospital. Over to Sumati ma'am to share few words on today's webinar.
Good evening. As we all know, our DENTOPHARM webinar series explores multidisciplinary research area, and we have eminent speaker Dr. Arumugam Balasubramanian today, who will be dealing with bone modeling and remodeling. Thank you, sir. Over to Ramya, please.
Just a little announcement on housekeeping before we get started. So if you have any queries during the presentation, please type them in the question box provided in the chat. And I warmly welcome our guest speaker, Dr. Arumugam Balasubramanian, who is an active research scientist and fellow at Harvard Medical School, Boston, which is one of the topmost and well-renowned institution in the world. He is actively doing research for more than 4 years at Harvard Medical School. He is working towards connecting young minds to strive towards success and achievement. He is a well-recognized researcher in the field of endocrinology and bone biology. He has published numerous papers, more than 12 papers, in highly reputed scientific journals like Lead Journal of Cellular Physiology, JCCS, etc. His outstanding contribution in science brought him more than 560 citations with H index 10. He is actively indulging in research and studying the underlying mechanism of bone remodeling. He is well known for identifying the novel underlying mechanism of osteoblast differentiation via master transcription factor RUNX2. He elucidated the signaling pathway responsible for bone development and its current useful for treating a bone-related disease. His recent discovery at Harvard on therapeutics approach for sepsis is outstanding and promising. His excellence in biology is truly inspiring and motivating young minds. We welcome you, sir.
Okay. Shall I begin?
Yes.
Okay. Good evening to one and all who present here. I sincerely thank Dr. Sumati Jones for organizing the conference and inviting me to giving the talk about the bone remodeling. I'm happy to give some self-introduction and about the bone remodeling. I hope everyone can understand the topic of bone remodeling at the end of the discussions. If any of you have any questions, please stop me anywhere in between. I'm happy to answer for the questions. Okay. So today we are going to talk about the physiology and pathophysiology of bone remodeling. So myself, Arumugam Balasubramanian, I am working as a senior research fellow and also a scientist at Department of Laboratory Medicines at Harvard Medical School, Boston, Massachusetts, USA. So let's see the basic introduction about the bone. What is bone? The bone is a highly rigid complex and it is a connective tissue. It is complex is form of the skeletal framework of the human body. If you look at the typical structure of the bone, so that the bone, it comprises of various cells. Like for example, osteoblast, osteoclast, and osteocytes. We'll see detailing about what are these type of cells, how these cells interconnect each other, and what are the signaling pathway merge these osteoblasts, osteoclasts, and osteocytes. And what if there is any deregulation in the particular gene in the osteoblast that leads to various bone diseases? So, if you look at the typical structure of the bone it has the connective bone. It is actually is a connective tissue. It is a hotspot for the producing the bone marrow. As we all know about the bone marrow, it produces a lot of cells like hematopoietic stem cells. From the hematopoietic stem cells, it originates a lot of bone cells such as osteoblasts, osteoclasts, and osteocytes. So the end of a long bone that is called epiphysis is separated from the sad bone. It's called actively proliferating cartilage. And also the linear bone growth, it acts as epiphysis separated from the sad of the bone, that is called epiphysis closus. So what are the major functions of the bone? So bone is the major organ and it's involved in the regulating the calcium and phosphate homeostasis. And it also helps to protect the vital organs, and it helps in permits the locomotion and support the gravity. It contains a hotspot of the bone marrow cells, that is the blood cells, and also is a reservoir for calcium and phosphate. So if you look at the composition of the bone is majorly comprised of the collagen fibers. For example, the bone is divided into two parts. Like one, the 30% is made up of organic matrix. Organic matrix in the sense like it's made up of collagen fibers, 90 to 95%. In the ground substance, for example, the 5 to 10% is made up of proteoglycan. There are some certain extracellular matrix called chondroitin sulfate that is necessary for attachment. And the 70% is made up of bone salts. What are the bone salts? Like, for example, the calcium and phosphate, and there are certain cofactors such as magnesium, sodium, potassium, and carbonate ions. So next we will move on to the what are the cells involved in the bone formation and bone resorption. So in the previous slide we saw that like what are how what are the composition of bone, and then we need to study about what are the cells involved in the bone formation and bone resorption. So the bone marrow is the hotspot for producing the stem cells. For example, from the bone marrow, it starts produce hematopoietic stem cells. That hematopoietic stem cell it leads to form osteoclast precursor to osteoclast cells. From the mesenchymal stem cells, it produced osteoblast precursor cells. The osteoblast precursor cells is produced osteoblast. So there are various types of bone cells. For example, osteoblast, osteoclast, and osteocytes. The bone remodeling is covering about how these osteoblasts and osteoclasts communicate each other and what are the signaling pathways is converged this bone remodeling. Let's see about what is osteoblast. Osteoblasts are the bone forming cells. It's derived from mesenchymal stem cells. It produces a lot of the osteoblast cells secrete a lot of growth factors that is essential for osteoblast differentiation. When the bone forms, the bone resorption starts. So that bone resorption is mediated by osteoclast cells. That is a bone degradation. The bone degradation cells called osteoclast cells. It is mediated by certain factors such as, for example, parathyroid hormone, calcitonin, and IL-6. The osteoblast cells secrete and produce rankle. Osteoblast cells have the receptor for rankle, and the rankle goes and bind to the osteoclast cells, and it regulates the bone degradation. The parathyroid hormone is one of the major hormone. It involved is in the secretion of lot of growth factors and co-transcription factors, which is necessary for bone resorption. Osteocytes are the mature bone cells. So when the mature bone cells is produced, it secretes serotonin, so that inhibit the bone formation, because there are some stages once the bone formation, and then once the bone formation occurs, and then the bone undergoes osteoclast. So this is called coupling mechanisms. Next, we'll see about what is odontoclast. Odontoclast is generally classified as the osteoclast associated with absorption of the root of the deciduous teeth. So these are the various classification of the bone cells. So next, we will see in depth about what are the cellular and molecular mechanism of bone formations. So in the previous slide, we saw that there are various type of bone cells such as osteoblast, osteoclast, osteocytes, and odontoblast are involved. But how these cells are produced? What are the molecular pathways? What are the signaling pathways involved? We'll look into in these slides. For example, the TG beta. So the TG beta is called transforming growth factor beta 1. It is one of the most abundant growth factor, and the TG beta 1, it has several variants: beta 1, beta 2, beta 3. The TG beta 1 is bind to the TG beta receptor. Once it bind, it has a various downstream signaling pathways such as MAT pathway, MAP kinase pathway. Through various signaling pathway, TG beta acts as the central mediator and hotspot for the bone formation. So the TG beta is essential for the mesenchymal stem cell to convert to osteoblast progenitors and also the osteoblast formation. And the TG beta is also essential for hematopoietic stem cell to produce osteoclast precursors. TG beta also essential to produce upregulate the gene expression of RANKL and OPG. So it typically indicates that TG beta is one of the most abundant growth factor. It is essential for the bone formation and also the bone resorption. It's not only about the TG beta because the bone is a converged and it involves a lot of multiple signaling pathway. Through multiple signaling pathway, the bone connect each pathway to form the bone formation and bone resorptions. For example, if you look at this typical picture, this is the pathway which connect all signaling pathway which regulate the bone formation, bone resorption. For example, the TG beta, it goes and bind to the TG beta receptor 1, receptor 2 and 3, and it upregulates the expression of SMAD. Through that SMAD is the co-activator. So the SMAD go and bind to the predominant gene that is called RNX2. We will look on to the next slide what is RNX2 and what are the genes involved in the bone formation. And also there are other signaling pathways such as BMP, bone morphogenesic protein, and the parathyroid hormone and the Wnt. So these all pathways are interconnected. So for example, when there is a bone formation, you always see that there is the TG beta plays a predominant role. When there is a bone resorption, so the signaling pathways it's switched to the PTH. So when there is a PTH upregulated, when there is high level of PTH, the PTH it secretes the bone resorption factor. So that through the MMP matrix metalloprotein signaling, and it involved degradation of the bone, and it also mediated various hormones including serotonin to regulate the bone resorptions. Depend upon the particular lineage, when the cells need to respond to osteoblast, when the cells need to go for an osteoclast, the growth factors, expression, and also the pattern, it also changes. So next we will see about the BMP. So we saw in the previous slide, we saw that what is transforming growth factor. In this slide, we see what is the BMP. BMP is one of the bone morphogenesic proteins. It is one of the bone hormones, and it also involved in the osteoinductive proteins. It is necessary. There are several BMP, like BMP 1 to 17, BMP 1 to 7. BMP 2 and 7 is particularly involved in the bone formation, and BMP 3 is extremely potent inducer of mesenchymal differentiation. And BMP 1 is involved is acts as an enzyme that involved in the cleavage of pro-collagen. Collagen, we all know that pro-collagen is most comprises of the bone. So next we'll see about parathyroid hormone. So what is parathyroid hormone? PTH. PTH is one of the most essential hormone. It regulates the multiple functions. So it actually secreted from the parathyroid hormones. Once it's secreted, when the PTH is secreted, for example, if there is a low level of calcium in the blood, So the parathyroid hormone, it sends the PTH. The PTH expression level will change. The upregulated PTH, it actually circulated into the blood. Before circulating to the blood, it actually it's bind to the PTH receptor in the osteoblast, and then it releases the calcium and release into the blood. And when there is a decrease, when there is a high regulation of the PTH, it has opposite signal. So the PTH is also essential for observing the calcium, not only release hormone, it also essential for observing the calcium from the kidney and also for observing the calcium in the intestines. So the PTH involves the converse signaling pathway. It's a major role in maintaining the calcium homeostasis and also the bone resorption. So next we will see in depth about what are the molecular signaling pathways, what are the factors, what are the genes which involved in the transcriptional regulation of bone formations. So let's look about the genes which regulate the bone formation and bone resorptions. For example, mesenchymal stem cells during the predominant stage, in the preliminary stage, the mesenchymal stem cells, it secretes various factors that is essential for forming the mesenchymal stem cell. For example, the SOX2 and the BMP and also FGF2. When there is osteoprogenesis, the mesenchymal stem cells need to convert to osteoprogenic cells. During this stage, there are certain genes which, for example, the RUNX2, OSTX, these expressions is regulated. And during this stage, there is a decrease in the expression of TWIST1 and TLE and HOX2 and other factors. After osteoprogenitor cells, it arises and it gives the pre-osteoblast. During pre-osteoblast condition, the RUNX2 level is not very high and the level is keep on changing. And during the osteoblast, once the pre-osteoblast converted and then it gives and rise to the osteoblast. During the osteoblast differentiation, you can see the very high level of RUNX2. That is the most prominent transcription factor that is essential for bone differentiation. And also there are some markers, for example, alkaline phosphatase, collagen, type 1 collagen. These are the markers. It also regulated by the predominant transcription factor RUNX2. Once osteoblasts rise and it actually gives a rise to the mature formation, mature bone forming cells that is called osteocytes. During this stage, the RUNX2 level is actually it get decreased. After the osteocytes, then the osteoclast it starts. So this is like the coupling mechanism and how the mesenchymal stem cells it start to rise to osteoblast to osteoclast with the help of various transcriptional factor involved in the gene development. If you look at the picture at the right, you can see the RUNX2. The RUNX2 is the predominant transcription factor. It is regulated by the RUNX2 recocytine growth factor. For example, transforming growth factor and parathyroid hormone depend upon the particular stimulus. The RUNX2 expression and activity also change. If there is upregulation in the transcriptional activity of the RUNX2 expression alter and it go and bind to the various downstream gene, for example, alkaline phosphatase and collagen 1 that is essential for bone mineralization. So once it bind to this ALP and collagen, the gene synthesis also will be upregulated. So these RUNX2 expression deepen upon the cell type. For example, if you look at the osteoclast, the RUNX2 expression is not altered. If you look at the osteoblast precursor cells and also osteoblast cells, the RUNX2 expression level is very high. When there is a complete differentiation, the RUNX2 level will go down. So it's depend upon the particular stimulus, depend upon the particular cells, the RUNX2 gene expression alter. So how do we know that RUNX2 is essential for bone differentiation? So the first group, Komari from the Japan, he is a great Japanese scientist. He was the person who first discovered that the RUNX2 gene, RUNX2 is essential for bone differentiations. So first, what he did, if you look at the picture on the picture on the left side, you can see there's the pups, the mice. There's a one the wild type, the plus plus, and the plus minus is the heterozygous dominant, and the minus minus that is the homozygous. The complete knockdown of the RUNX2 it leads to complete absence of bone formations, and there is no clavicle formation. There is no bone formation. In the C, you can see that's the day 15.5, this embryonic stage. You can see that the bone formation is completely lost when there is a two copies of the RUNX2 gene is mutated. So this indicates that RUNX2 is essential for bone differentiation, bone formation. If there is no RUNX2, you cannot see there is a complete defect in the bone formations. So the next, myself and one of my colleague, Dr. Vimal Raj, he written a review article about we were very interested about what are the various pathways which converge the RUNX2, because since RUNX2 is essential for osteoblast differentiation, and then we found that we connected all the signaling pathways. RUNX2 can be activated by multiple signaling pathway, for example, AKT kinase and also ERK-MAP kinase, and also there are some other kinase like other signaling pathway Wind. So these are the typical structure of the RUNX2. It has both transcription and translation, and but these are the sites, the typical sites where there is a phosphorylation, and how these kinases go and bind to the RUNX2 genes. So next, I investigated how this RUNX2 gene expression altered and how this RUNX2 is regulated by transforming growth factor beta 1. Since RUNX2 is essential for osteoblast differentiation, so I investigated upon TG beta stimulation, and I found that upon TG beta stimulation, there is TG beta alters the translation level of the RUNX2. Based on the mass spectrometry, high throughput mass spectrometry, so we discovered that the TG beta actually it stimulated the and induced the phosphorylation at the RUNX2 sites at three sites: serine 233 and 236 and 240. These three sites are phosphorylated by transforming growth factor, and these phosphorylated sites, this phosphorylation is essential for bone differentiation. So in this study, we found that when we mutate these sites, we saw that the osteoblast differentiation is completely reduced. Bone mineralization, such as calcium deposit, is also reduced. This indicates that TG beta can alter the RUNX2 phosphorylation and induce upon the RUNX2 phosphorylation. That phosphorylation is essential for osteoblast differentiation. So if you look at the picture on the left side, so that's the first one. Upon the TG beta stimulation, there is the RUNX2 is phosphorylated at serine and threonine, predominantly at serine residues rather than threonine tyrosines. And further, based on the mass spectrometry, and we discovered that there are three sites which is essential for RUNX2 phosphorylation that is specifically mediated by transforming growth factor beta 1. When we mutate that sites, the three sites, we saw that there is a complete reduction of RUNX2 phosphorylation, and also there is a complete reduction of the MMP13 gene expression that is essential for bone resorptions. So the TG beta signaling pathway. So it is actually the TG beta actually goes and bind to the TG beta receptor 1 and 2. After it bind, it has a two signaling pathway. One is a SMAD signaling pathway, and the other one is the ERK-MAP kinase signaling pathway. So TG beta activate the MEK signaling pathway. Through MEK signaling, the MEK it activates the ERK. The ERK phosphorylated ERK, it goes and binds to the nucleus. It enters into the nucleus. It goes and binds to the RUNX2, and the RUNX2 is getting phosphorylated by MAP kinase, ERK kinase. So once the RUNX2 is phosphorylated, the RUNX2 activity, the expression will not change. The RUNX2 activity will change. That activity, the alternate in the RUNX2 activity, it goes and bind to the matrix metalloproteinase 13 that is essential for bone resorption and bone degradation. So once there is a change in the Runnext activity. The Runnext goes and bind to the MMP13. The MMP13 expression level is halted. So this indicates that TG beta, transforming growth factor beta, is essential factor for regulating the Runnext to post-translational activity. That Runnext to phosphorylation is essential for bone remodeling, such as osteoblast differentiation and also osteoclast. So the next we investigated what are the other ways the Runnext2 gene can be altered. So we in the previous slide we saw that the TG beta through TG beta signaling, the Runnext2 post translation level alter, and that activity is essential for bone cell differentiation. Next, we investigated upon parathyroid hormone. We noticed that the Runnext2 is very essential hormone, and it is necessary for both bone formation and also the bone resurgence. Upon the PTK stimulation, so the Runnext2 transcription level alter. When the Runnext2 transcription level alter, you can see that parathyroid hormone, that is bone co-sustaining during the bone cell differentiation. In the primary cells, upon parathyroid hormone cells, it actually stimulates the Runnext2. The Runnext2 is involved, it upregulates the various bone formation factors such as alkaline phosphatase and type 1 collagen, etc. And the figure 1C, you can see that the Runnext expression has keep on changing upon the treatment with the PTH for different days. For example, in 7 and in the 14 days, you can see the maximum peak of Runnext amount expression level change. So the PTH, the parathyroid hormone stimulation of Runnext2 is completely depend upon the concentration and the type of stimulation. For example, the parathyroid hormone, it has two different roles. One is the continuous and another is intermittent dose. In the continued dose, it has opposite role. It actually represses the Runnext expression. When there is intermittent dose, you can see there is always upregulation of the Runnext2. That leads to bone formations. So parathyroid hormone actually it even in the current clinical trial, and also it has been used as a early for only treatment for the osteoporosis. So the intermittent treatment, it helps in the forming the building the bone, and the continuous treatment, it actually resorbs the bone. So next we'll talk about the what are the other ways the bone cell differentiation, such as osteoblast differentiation, is regulated by microRNAs. The recent discovery of microRNAs and long non-coding RNA, it plays a significant role in the bone cell differentiation. MicroRNA, what is microRNAs? So the microRNA is a short 10 to 20 nucleotides. It's basically, there are a lot of genes. The microRNA is specific for one particular gene we can design, and it regulates at the post-transcriptional level. For example, the DNA can be usually transcribed into the mRNA, and the mRNA translated into the protein. The microRNA can be a factor. It may also inhibit the translation, and also it promote the translation activity. So the mesenchymal stem cells are the hotspot, and it's multipotent. It undergoes a differentiation into osteoblast, osteoclast, chondrocytes, and myoblast. So during the mesenchymal stem cells, there are particular microRNA expression may alter depend upon the particular stimulus. For example, the parathyroid hormone, transforming growth factor beta, BMP, it alters certain microRNAs. That microRNA will go and bind to the certain transcriptional factor, which is essential for bone formation, and it may inhibit or it may promote, depend upon the particular stimulus and depend upon the particular microRNAs. So, initially we initially during, as we all know that the bone differentiation also changed during the 14 days. We can see there is upregulation of the bone formation, the crystal formation, calcium absorption, and also the down, that is upon the osteogenic media, that is one cause sustaining. During the 14 days treatment, we can see there is upregulation of ALP, osteogenetic, ostrix, and type 1 collagens. So this indicate that during bone differentiation, certain bone forming markers it also express. Depending upon the particular conditions, it may also change. Next, he investigated and he studied and he discovered that he screened several microRNAs. Out of several microRNAs, he found that one of the microRNAs, such as 15B, it actually it has a regulated the expression. It regulated the next expression in mouse mesenchymal stem cells. So what he did a several high throughput screening, and he discovered one of the microRNA which actually directly regulated the next expression. How this next expression is regulated through microRNA? So this microRNA 15B, it actually target the core repressor of RNX2. So the RNX2 activity, it also depend upon later and core repressors. So this microRNA 15B depend upon the particular stimulus. So the expression level it increase. Once the expression level it increase, it actually goes and bind to the SMRF and it target the SMRF and it degrade the SMRF. The degradation of SMRF, it's actually it increase the expression of RNX2. There is increase in the expression of RNX2. It actually promotes the osteoblast differentiation. Here we can see that in the negative control, that is a microRNA 15B mimic and also the inhibitor. So the microRNA 15B mimic, when he used the microRNA 15B, you can see that is the high upregulation of the RNX2 expressions. So this is indirect regulation. Indirect regulation in the sense microRNA 15B, it target the co-repressor of RNX2, such as MRF1 and SMAD1. So by targeting the co-repressor of RNX2, the RNX2 expression level alter. The altering the expression of RNX2, you can see there is a more osteoblast differentiation. This indicates that this microRNA, particular 15B microRNA, plays a crucial role in regulating the RNX2 expression during the bone differentiation. So these are the typical pathway. He discovered that microRNA 15B from MSC mesenchymal stem cells during osteoblast differentiation, microRNA 15B expression altering the microRNA 15B expressions. The microRNA 15B it inhibits the objective signaling pathway. It inhibits the SMRF1 because the SMRF1 it goes and bind to the RNX2. When there is upregulation of SMRF1, what will happen? So the SMRF1 is a co-repressor of RNX2. So the SMRF1 it inhibits the RNX2. If the microRNA inhibits the SMRF1, you can see there is a more upregulation of RNX2. When there is upregulation of RNX2, you can see more osteoblast differentiation. So this is the various signaling pathway, like how the microRNA regulate the RNX2 for osteoblast differentiation. So next, we also investigated using the parathyroid hormone how the MMP13 is regulated. What is MMP13? MMP13 is a matrix metalloproteinase. So that is essential for bone formation and also bone resorption. When there is any defect in the matrix metalloproteinase, you can see more calcium absorption, you can see more degradation. So MMP expression, MMP13 expression, it's completely depend on the stimulus, such as TG beta and also parathyroid hormone. So the PTH has the ability to alter the MMP13 expressions. So once there is a regulation of MMP13 during osteoclast process, bone resorption, the PTH hormone, it go into the PTH, go and bind to the PTH receptor. Once it binds to the PTH receptor, the MMP13 expression altered. When there is upregulation of MMP13, it leads to continues the process of bone resorption. So we discovered that there are certain microRNA which is regulated by PTH, and that microRNA is essential for targeting the MMP13 gene expression in the bone. We culture the bone cells from the primary rat calvarious cells and we differentiated into osteoblast. And then we discovered, we screened certain microRNAs which can target the MMP13 gene expression. So upon screening several microRNAs, we found and noticed that microRNA 532 is most essential microRNA is actually directly target the MMP13. So when there is a PTH stimulation, there is the microRNA 530-15P expression upregulate, and upregulation of 513-5P, it goes and bind to the MMP13 and it decreases the expression of MMP13. So if you look at the Western blot analysis, you can see that parathyroid hormone, it enhances the expression of MMP13. And upon the microRNA 15-5P by treating the cells with P, you can see there is a decrease. So that means that microRNA 5P, 5 microRNA 532 is essential for targeting MMP13 during the bone resorptions. And also in the down, you can see the PTH treatment upon of the different conditions and the different treatment, different time points. You can see that upon in the 4 hours treatment, you can see very high level of MMP13. As I already told that the PTH expression is complete, PTH stimulus is completely depend upon the type of treatment. Continuous treatment, it has opposite role, and intermittent treatment has a different role. So intermittent treatment has positive role in the bone formation. The continuous treatment has negative role in the bone formation. That the continuous treatment it leads to the bone resorption. And also in additionally, we also investigated how the parathyroid hormone regulate RNX2 apart from the microRNA. We also discovered that the novel long non-coding RNA that is essential for bone formations. The long non-coding RNA is longer than microRNA. It's more than 20 to 30 nucleotides in sequence. So that is specifically targeted the RNX2. We designed and we discovered that there are few LNC RNA which directly target the microRNA 6797. It acts as a sponging in the sense that microRNA depend. For example, if you give the PTX treatment, the microRNA 67975P it upregulate. The microRNA 67975P expression level alter, and then long non-coding RNA inhibit the microRNA 797, and then it it inhibit the RNX2. So this is the ways how the microRNAs and long non-coding RNA it works. Here we discovered that microRNA 6975P it has a positive role in regulating the RNX2 expression during the bone cell differentiations. And also additionally we investigated the transforming growth factor, how the transforming growth factor targeting upon TG beta stimulation. We screened we screened several microRNA. The expression level altered. Among several microRNA, we found one microRNA is significantly affected. That is microRNA 203A5P. So this upon TG beta stimulation, this microRNA the expression alters. This microRNA 203A5P it goes and bind directly to the MMP13, and the MMP13 expression level is altered. So why we need to study about MMP13? Because the MMP13 matrix metalloproteinase 13 is essential for bone formation and also the bone resorption. If there is a dysregulation in the MMP13 gene expression and also the RNX2, it leads to various bone disorders, bone diseases like cradocranial dysplasia, osteoporosis. So we need to study about what are the significant that's why we studied about this microRNA. So this indicates that microRNA is essential for bone differentiation. There are several microRNAs. There are several microRNAs. It's under the clinical trials, and also it has been widely used for the disorder. The problem is it has very less stability. So that's why the treatment is not 100% succeed in the microRNA based therapy. So the next, we also discovered that polyphenols For example, there are other ways, like the naturally available. We know that in the daily intake, we take a lot of polyphenols through the vegetable sources. The vegetable sources and also the plant compounds is rich in polyphenols. So the polyphenols such as syringic acid, phenolic acid, ferulinic acid, so all the compounds is had directly influence the bone. How it influences the bone? Through the RNX2 signaling pathway. So if you look at this picture, so the different doses of polyphenolic acid, that's syringic acids, has has in positive role in regulating the bone formation. It indicates the aligerine stain. The aligerine stain is for the bone formation, bone calcium deposition, and also the bone core sustaining. The different dose, it actually it has a positive role in the bone formations. And also the treatment of syringic acid, it targeted the microRNA 21-5P that was discovered by one of my colleague, Dr. Vimal Raj. So this microRNA 21-5P, it target the core repressor of RNX2. What are the core repressor of RNX2? RNX2 core repressor such as MAT7, it inhibits the RNX2 expressions. The microRNA 21-5P, it indirectly targeting the core repressors. So the most are available polyphenols. What we discovered that polyphenols, how it influences the bone formation, it acts the signaling pathway via RNX2. The polyphenols, it actually upregulated the microRNA 21-5P. If there is upregulation of 21-5P, it goes and bind to the SMAD and it inhibit the core repressor of SMAD7. Once it inhibits, you can see there is a more upregulation. This is how the typical molecular signaling pathway, it works in the cells. So there are certain growth factor or require most predominant transcription factor, such as RNX2 in the fibroblastic. So next we will move on to the bone remodeling. So we will see in the previous slide we saw that how the multiple pathways, the interconnecting pathway that is bone remodeling. So as we know that osteoblasts is actually build up the new bone and osteoclast is a break. So in the bone remodeling means you have the opportunity to have every bone, every remodeling occur. That in the bone remodeling that leads to musculoskeletal disorders and bone diseases. So the bone remodeling it's comprised of the various stages, such as for example in hematopoietic cells, pre-osteoblast cells, and osteoclast cells is actually secreted from the mesenchymal stem cells, and the mesenchymal stem cells rise to osteoblast and osteoclast, and that leads to osteocytes and build up the bone. When there is a osteoclast, the bone resorption, the newly born formed bone can be degraded. Metalloproteinase, one bone. This is a continuous process. If there is any defect in this process, that leads to the bone diseases. So this continuous process, the renewal rate is about 4% per year for compact bone and 20% for the trabecal bone. What is osteoclast? Because the bone remodeling, the most predominant role that is osteoclast. The bone formation, osteoclast occurs. Osteoblast cells have the receptor for osteoclast gene, such as Rankel OPG. Osteoclast cells, it actually don't have the receptor for that. So the osteoblast cells have the receptor for Rankel OPG, that is the most essential factor for the bone deformation. Some of these rankle OPG expression is altered. This is hormone. So the osteoclast cells are two types of. It actually the protective proteolytic enzymes from the lysosomes, several acids from the mitochondria, and also secretory vesicles. The enzymes dissolve organic matrix and acid cause the solution of the bone cells. So what are the systematic regulation of bone remodeling? So we studied about what are the various cells and what are the various growth factor, what are the various mechanisms through the osteoblast and osteoclast, such as bone formation and bone resorption and let's talk about the bone disease classifications. So if we to classify the bone disease, actually bone disease classified into two types. One is the genetic and another is the acquired. The congenital disease is actually genetic disease, and the congenital disease plus of various the bone disease such as, for example, osteogenesis imperfecta. It is called brittle bone disease caused by the abnormal secretion of type 1 collagen, and another one is achondroplasia. There is a point mutation in Hepj that results in the chondrocyte proliferation. Then osteopetrosis. This is a rare genetic disorder. It's caused due to the osteoclast bone resorptions. There are other types of, other than the genetic that is occurred, that is metabolic. It's caused by metabolic disease. There is upregulation or deregulation of the various growth factor or gene. That is, for example, various growth factors. Osteoporosis. Osteoporosis is one of the reduction in the bone density leads to more fragile and high fracture. And also called Paget disease. Paget disease is one of the bone disease. It's actually caused the defect in the bone remodeling. During that condition, there is a high level of gain in the bone mass. The bone remodeling is disturbed, and not synchronized. Rickets and osteomalacia. This is a more defect in the vitamin D, defect in the vitamin D bone mineralization. And hyperparathyroidism, that is caused by the excessive parathyroid hormone, resulted in the increased osteoclast activity and bone fractures. So I'm going to talk about osteoporosis and cleidocranial dysplasia, only about the few bone disease that is it's caused by the defect in the RUNX2 gene and also the parathyroid hormone. Okay, let's talk about the cleidocranial dysplasia. This is one of the most bone disease, very rare disease. It's caused by the defect in the RUNX2 genes. So the RUNX2 gene is actually it's mutated during this condition. So due to the defect in the RUNX2, there is a bone teeth malformations and the misregulations in the bone RUNX2 gene that leads cause some genetic disease and very brittle bone disease. So if you look at the typical structure of the RUNX2, the transcription level during the genetic disease, in the genetic disease of cleidocranial dysplasia, there is a mutation. The mutation at the RUNX2 90 kilobase per deletion of RUNX2 that is associated with the cleidocranial dysplasia. So there are several nucleotides is actually mutated in the cleidocranial dysplasia. It's not only about the one particular mutation in the RUNX2 gene. There are more than 10 missense mutation is reported in the RUNX2 that leads to the cleidocranial dysplasia. This is one of the discovery, the first made from the Chinese colleague. He discovered that the defect in the mutation of RUNX2 gene and in the coding sequences, it leads to malformation of the bone that leads to the cleidocranial dysplasia. So during the cleidocranial dysplasia, that is a skeletal disease. So what will happen? The RUNX2 transcription level, the RUNX2 level is inhibited, and due to defect in the RUNX2 mutation, due to the presence of mutation in the RUNX2 expression level also alter. The decrease in the RUNX2, it leads to delay in the closure of the skull region. In the normal condition, the RUNX2 expression is altered, and during the osteoblast differentiation, RUNX2 level upregulated. After osteoblast, then osteoclast, the expression level go down. This leads to normal closure. In the premature closure, the RUNX expression is very high, so that leads to premature closures. During the cleidocranial dysplasia, the RUNX2 expression level is inhibited due to the presence of mutation in the coding sequences. So that for the cleidocranial dysplasia is a genetic disease. It's caused by the mutation in the RUNX2. There are various group of scientists. They found that by targeting the RUNX2, we can rectify the musculoskeletal disease. How to target the RUNX2? The RUNX2 target by the ERK-MACPA signaling pathway. These are the various inhibitor which is available to treat the cleidocranial dysplasia. There are some therapeutic intervention. So, for example, the ERK-MAP kinase signaling pathways such as SB20 and E01 things, these inhibitor has promising because when you treat with this inhibitor, actually the RNX phosphorylase inhibitor, when there is inhibiting the phosphorylation of RNX2, and you can see there is a the defect will be can be cleared. And also there is indirect inhibitors such as by targeting the co-activator, co-repressor of RNX2 such as P300 and the PIN1. These are the various inhibitor which available available so far in the clinical trial and also successfully in for treating the clinocranial dysplasia. By using this inhibitor, we can partially clear the musculoskeletal diseases. So, what are the available treatment for the cleidocranial dysplasia? So, the treatment depends on how the syndrome affects the patients. For example, people with the cleidocranial dysplasia undergo multiple orthopedic facial reconstructive dental procedures. For example, for in the children, the facial reconstructive surgery on the bones of the face to reshape the forehead or cheekbones, and also spinal fusion process support to support the spinal column, and also the lower leg surgery, surgical repair, and removal of small collarbone pieces that can affect the brachial flexus and also ear tips. Apart from the physical reconstruction, the other treatments such as calcium and vitamin D supplements to strengthen the bones. There is no direct approach for treating the cleidocranial dysplasia. It's due to genetic disease. We can overcome the other situation by giving to boost the bone, like by giving the calcium and vitamin D supplements. Next, we'll talk about osteoporosis. Osteoporosis is also the brittle bone disease. It is a silent disease. It's complicated by fractures and it characterized by the presence of low bone mass, microarchitectural deterioration, com- compromise bone strength, and increased risk of fractures. There are certain risk factors which leads to osteoporosis. One is the age factor and history of fracture in the past, and also the low body weight, current smoking, and use of oral corticosteroid. And also like dementia, poor health, recent falls, and low calcium intake. These are the various factors osteoporosis. It leads to osteoporosis disease. So in the osteoporosis disease, one of the predominant factor that is a parathyroid hormone, because if there is a defect in parathyroid hormone, that also leads to osteoporosis, because osteoporosis is essential for regulating the RUNX2 gene, and there is a defect in the RUNX2 MMP13 that leads to osteoporosis. There are some molecular features for osteoporosis. It's not only about the RNX2, and it also from the mesenchymal stem cell. If you look at the Piper gamma and hematopoietic cell defect in the NF-kappa signaling pathway, and there is a defect in interleukin segment, there are various factors which actually contribute to the osteoporosis. There are different molecular signaling pathways. For the osteoporosis, if you look at the therapeutic interventions, there are various drugs. The drugs are classified into anti-receptor drugs, just by bisphosphonase, and also the selective estrogen receptor modulate and hormonal replacement, and also calcitonin. There are certain bone forming drugs such as parathyroid hormone, intermittent administration of parathyroid hormone is actually used for treating the osteoporosis and other bone diseases. The teriforatide, that is actually is derived from the parathyroid hormone, that's 1 to 34, that has been used widely for treating the osteoporosis. There are certain other drugs combined which leads for curing the osteoporosis, such as vitamin D and denosumab and strontium. These are the therapeutic interventions so far for treating the osteoporosis diseases. There are some FDA approved drugs for osteoporosis, and there is the bisphosphonase and the trade name, and there are certain selective estrogen receptor modulator, and there are certain called serotonin, like parathyroid hormone, that is 1 to 34, that is used for treating intermittent administration, used for treating the osteoporosis, and also the certain hormonal therapeutic interventions. These are the FDA approved drugs for the osteoporosis. So, how to overcome this osteoporosis? How we can improve the osteoporosis health conditions? How can help? How can health professionals improve the bone health? To help patients maintain strong bone and healthy bones, healthy should consider and identify recommending the appropriate treatment for the individual at higher risk for osteoporosis and other bone diseases. Just recognize risk factor that were and osteoporosis screening and assessing diet lifestyles, advise patient to take additional steps to ensure bone health, and be familiar with the treatment of osteoporosis, and actively look for the other bone disease that leads to bone loss and bone fractures. So next we will look about what are the other ways we can treat the bone diseases. The biomaterials is one of the alternative approach and easily available approach for treating certain bone defect. There are plenty of biomaterials is available in nature that can be used for treating the bone defect. It's easy to produce and low economic cost, and it has a less side effect too. So the bone tissue engineering actually is one of the promising field. It involves comprises of using the biomaterials to treat the bone diseases. So how the bone disease, for example, if the patient has an injured bone, so the injured bone can be healed and can be replaced by incorporating the biomaterials. The biomaterials is the materials derived from the biological source that have the bone healing effect. Upon incorporating this biomaterial that has very good capability for reconstructing the bone, so this is one of the most promising approach that's for treating the bone diseases. The bone defect and bone tissue engineering. The various bone defects can be rectified by bone tissue engineering. For example, isolating the bone cells from the healthy person, and then incorporating into the and then growing the healthy cells in the in vitro condition upon the different stimulus, and then incorporating those cells into the biomaterials, and then incorporate into the defective bone. There are various approach to treat this bone disease by using the bone tissue engineering. That's one of the promising approaches, that's using the biomaterials, naturally available biomaterials. So this is one of the study done by my colleague Dr. Salvanan. He he discovered that mesoporous volosonide particles on mesenchymal stem cell differentiation by one co-sustaining. He used mesoporous volosonide is actually he isolated from the natural sources, so that have the capability for inducing the bone formation and also differentiations. He cultured in the bone cells, and he found that it has a capability to induce the bone formations. This is the typical bone co-sustaining. You can see that when the cells cultured in the mesoporous volosonide that is isolated from the rice starch, it has the biomaterial capability to induce the bone formations. It has a high mineralization rate. So the next, he also discovered that he found that there are certain biomaterials it has a capability to induce the osteoblast marker gene expression, such as alkaline phosphatase, collagen 1, and osteocalcins. So these are the bone differentiation markers. Upon the addition of the mesoporous volosonide biomaterials, you can see there is a upregulation of the osteoblast differentiation markers that is essential for bone formations. And also, if you look at the molecular signaling pathways, it also there are certain biomaterials. It has a capability to induce altering the next protein level that has the capability for altering the bone cell differentiation. Upon the stimulus with bone factors, such as for example, when the cells cultured with mesoporous volosonide, the basic biomaterials, it has upregulated the next expressions. That expression goes and bind to the regulating the various bone differentiation markers such as alkaline phosphatase, collagen 1, and other factors. And also he did the in vivo studies using the bone defect, and he applied the scorpopol and also mesophospholate, and he found that there's a protruding good healing effect upon incorporating the mesophospholate particles. So these are the typical histological staining of the bone cells, and you can see that upon incorporating the biomaterial cells, we can see that it's a complete healing effect of the bone. So this indicates that the biomaterials is still promising approach, and it is easily available. We can isolate from the naturally available sources, and it can easily incorporate into the bone without causing any physical harm and any side effect. That's this, that we can use it for treating the various bone diseases. Thank you. That's all. That's all I have. Any questions?
Thank you, sir. Thank you so much for your presentation. Over to Sumati ma'am for the question session.
Thank you, sir. You have explained in detail about the RNX2 and the gene expression, parathyroid hormone, the drugs used in osteoporosis in detail for our students and the participants. Uh, we have few questions actually, sir.
Sure.
These are the basic questions. Is there any bone tissue change in space flight, sir?
Bone tissue changes in space flight. So which space flight you're talking about?
This is the question in general asked. That's it. Will there be any change in space and over here in the bone tissue?
The bone space is be altered during the bone resorption. It's not. It will not be altered during the bone formation. When there is a deconstruction of the bone, there is always that the bone shape also is changed.
Okay, so what are the commonly used biomarkers, sir, for this bone fractures and all those?
So if you look at the common biomarkers for the bone fractures, the RNX2 expression, and also there is like a ALP, type 1 collagen, osteocalcin. So these are the typical indicator for bone mineralizations.
Okay. Next, is there any relation between body fat distribution and bone mineral density, sir? Body fat distribution and bone mineral density.
Yes, of course, because the body fat distribution is regulated by PPAR gamma signaling pathway. So that PPAR gamma signaling is essential for regulating certain gene expression in the bone formations. When there is a more fat depositions, so that fat contributes to more inflammation that leads to more osteoporosis. There are several bone diseases, inflammatory diseases connected with the through that signal.
Thanks to all the participants who have participated today. I would like to thank the institution Sri Balaji Dental College and Hospital, Dr. Sumati Jones ma'am, Head of the Department of Pharmacology, for conducting the series of webinar on DENTOPHARM 2022, Principal Sir, Dr. Jimson Sir, and the organizing committee, Dr. Satish N.P. Murli, and also to the guest speaker, Dr. Arumugam Balasubramanian Sir. Thank you so much, sir, for your presentation.
I thank you all for attending my talk. I'm really sorry that my internet connection is broken, and I would feel like to give more talk. Like I didn't have enough time to put all the things together. So I'm happy to answer whatever the question. If you guys have any question, please email to me. I will send an email shortly. So I have the meeting in a few minutes. I need to go for my work, and I have meeting with my colleagues at Harvard Medical School.
Okay, so thank you, sir. Thank you for accepting our invite, sir. Thank you so much.
Thank you so much.
Thank you, sir. Thank you so much.
Thank you.
And a special thanks to Dr. Nishad Sheikh and Angelin from Doc Mode Organization for the technical support.